Good afternoon, everybody. My name is Rhonda. I'm the Director of Federal.
Go ahead.
Good afternoon. There we go. Sorry about that. My name is Rhonda Orton. I am the Disability Administration Director of Federal Programs. We want to welcome you today to our second Waiver Advisory Council meeting. We're really excited to have the opportunity to get together again and appreciate you joining us. As per the charter, I am one of the council's co-chairs, and today we'll be introducing our new co-chair member that will be joining us, and we all look forward to working with you. Next slide, please. This slide is an overview of our agenda today. It includes the introduction of our co-chair and new members, the membership recruitment. We're going to talk a little bit more about that. We're going to have a presentation on Medicaid 101 and also a presentation related to the new federal access rule. We'll talk about some policy updates. We're also going to hear from the waiver recommendation work group today about the activities that they've been doing and their status. And we'll also have some public comment. Next slide, please.
And Rhonda, if you could speak up, the microphone isn't picking up well.
Thank you. I think we're at Marlene is welcome.
Good afternoon, everyone. I am Marlena Hutchinson. I am the Deputy Secretary for the Developmental Disabilities Administration. Thank you for joining us for our second Medicaid Waiver Advisory Council. We are going to go over some housekeeping things now, Rhonda.
Yep, thank you so much. And I'm going to try to talk a little bit more this way, just for the speaker. So if we go to the next slide, please, Will. So we wanted to go over some housekeeping items, specifically related to individuals and our members that have been able to join us virtually on the phone. First, we'd like to let everybody know that the meeting is being recorded. We want everybody to please mute their devices, and to mute your device, your microphone on your computer, please click on the microphone image noted in the first yellow arrow that's noted on the screen here. Questions and comments, to share those, we ask that you use the chat or the raise hand feature. To raise your hand, click on the hand image highlighted with the second yellow arrow from the right that's on the screen. To speak, you must first be recognized by the chair or co-chairs. For today's meeting, I will be chairing. Members of the Waiver Advisory Council can be recognized during the meeting, and members of the public can only be recognized during the public comment period, which will be conducted at the end of the meeting. We ask that you introduce yourself prior to speaking, and public comment period, again, will be noted at the end. And to come on camera, please click on the camera icon that we have noted here, highlighted by the second yellow arrow on the left of the screen. As we shared during our first meeting, it's really important for all of us to note, to ensure confidentiality, if you have a question specific to an application related to eligibility, a concern or services, we please ask that you contact the DDA regional office. You can approach and contact me after the meeting. We're happy to support and assist and look into those concerns for you. We do not want to do that during the public meeting. We need to ensure people's confidentiality and respect their rights. All comments and questions from the council member and the public must be appropriate to the topic, respectful, and civil. Next slide, please. We wanted to first start off with just the reminders about our ground rules that we talked about during our last meeting. It's important that we make sure that we're all focused on these and ensuring that we're complying with these. Sometimes ground rules are referred to as things like being respectful and of other participants, not interrupting each other, and also staying on topic. So the ground rules we have that are noted in our charter include, we want to assume positive intent with our actions and words, speak one at a time, so we need to refrain from interrupting each other. We want to speak in plain language, for example, refrain from using acronyms. We want to share information openly, promptly, and respectfully. We want to listen to others' points of views and try to understand other interests. We want to remain flexible and open-minded and actively participate in the meeting. We want to maintain a respectful stance towards all council members, and we want to limit distractions. For example, we should all turn off or silence our cell phones during the meeting. Next slide, please. Now, before we begin our meeting, we also want to ensure civility in all of our meetings. The free expression of diverse viewpoints is an essential value for our group. This freedom comes with the responsibility to engage respectfully, which involves treating one another with dignity and respect in good faith. Uncivil behavior, disruptive conduct, abusive language, threats, or harassment will not be tolerated and may lead to removal from the meeting. Next slide, please. So before we start our meeting, and with the introduction of our co-chair, we're going to go around and take roll to make sure we have logged and noted the members that are on the meeting today, in case there's any voting or information going forward. So I'm going to quickly go through the roll call, and if people could acknowledge either on the phone or in the room, that would be great. First member is Mr. Abram Udofia. Abram, are you able to join us today? Next, we have Alexander Fitzgerald. Alger Studstill, Dr. Alger Studstill from Department of Human Services. Elisa Jones.
Good
We have Elisa
afternoon.
Jones noted on the line. Azeb Aderi.
I'm here. Yeah.
Beth Lash.
Here.
Thank you, Beth. Caitlin Bishop.
Joining
Caitlin
virtually.
noted on the phone. Charlotte Whittaker.
Here.
Thank you, Charlotte. Danielle Meister from Department of Housing and Community Development. Elizabeth Benavides. Emily Sheedy, Delegate Emily Sheedy. Shetty, sorry, I apologize. Emily Rowe. We have Emily noted
Here.
on the phone. Eric Saber. Janine Zaloxi. We have Janine noted on the phone. Jessica Salmon. John Paul Lalavi. Joseph Walburn. Joshua Del Close.
Here.
Catherine Murray. Catherine's noted on the line. Karen Lee. Here. Kelly Fox.
Here.
Kelly's noted on the line. Kelly Cooper. Keisha Shaw. Lisa Thomas, Dr. Lisa Thomas. Marlo Lemon.
Here.
We have Marlo noted on the line. Martin Baker.
Yes, thank you.
Matt Rice. That's noted online. Matt Morgan.
Here.
Matthew Ramsey.
Here.
Maureen Van Stone. Michael Greiner. Nazla Worthen.
Present.
She's online. Nan Brenningham is online. Patrick Kearney. Thank you, Patrick. Patrice Miller. Rachel London. Here. Rob Baynard.
Here.
Stephanie O'Day. Stephanie Watkins.
Patty
Patty
Salem.
Salem.
Yes.
And almost.
Patty's online, okay. Suzanne Corr. And Teresa Howard, who's
Present.
noted online. Great. Thank you, everybody.
Right, if we could pause 1 second. Okay, there we go.
Great, so now we're going to introduce our co-chair for the new council. Just a couple reminders, the Waiver Advisory Council is composed of 33 voting members and at least 13 non-voting members, including state departments, legislators, and national associations. As per the charter, the meetings will be facilitated by 2 co-chairs, one of which is myself as the DDA Director of Federal Programs, and the other is a member that is voted by the council. The co-chairs agree to effectively manage meetings and ensure resources are available to adequately manage the meeting logistics, ensure all members who wish to have an opportunity to speak are encouraged to do so, promote collaboration and exchange of ideas among Waiver Advisory Council members, facilitate communication with subject matter experts and other groups, keep Waiver Advisory Council members informed of progress, provide Waiver Council members the opportunity to collaborate on making recommendations for DDA, provide technical expertise, take the group's feedback and perspective to consider and include when making final decisions, explain the reasons for accepting, not accepting, or accepting with amendments on recommendations, and to be open and transparent with sharing information and decisions. Next slide, please. So please join me in congratulating our co-chair, Charlotte Whittaker. Thank you, Charlotte. Thank you to all the candidates who ran for chair. We really appreciate the interest, and for the council members that voted. Charlotte, would you like to introduce yourself or share a few things?
I would just like to say I'm like really honored and excited to be able to bring my lived experience as well as co-chair, or as I've been calling it, co-bill.
Please also join me in welcoming new members with lived experiences. We have Matt Rice, Abraham Adofia, Joshua Duclos, and Patrick Kearney, who's with us today. Next slide, please. So we wanted to touch a little bit on membership recruitment. Can you go to the next slide, please? We currently have 5 vacancies for people with lived experience. To achieve this balanced representation between individuals with lived experiences in the self-directed service delivery model and the traditional services, applications for individuals in the traditional services or the community provider service model are currently being prioritized. The department, we have created 2 informational flyers that we shared last meeting. It's on the next slide. We'll share that again. We did share in our last meeting some of our strategies that we're using to help recruit additional members of people with lived experiences. We've shared our flyers with advocacy organization and with the council last meeting. We're also going to be sharing the flyers with our national core indicators in-person surveys that Liberty will be conducting, so more people can learn. And we'd like to take this opportunity to again open it up for discussion with council members. Any additional ideals or strategies that you would like to suggest that we can help with the recruitment of additional people with lived experiences using the community provider service delivery model. Anybody has any ideals, or council members online want to raise your hand, we will recognize you. And having seen none, I will encourage you, if you have an ideal after the meeting or at some time, please reach out to myself or Charlotte. let us know, and we're happy to bring that back and look at those opportunities. Can you have the next slide, please, Will? This is the link to those flyers that we mentioned. It's also on the website, so please encouraging all of us to help to continue to get the word out for people. You go to the next slide, please. Now we're going to go.
Can I ask a quick, is there like a specific region you're looking for or that could help us to anywhere?
Just people who are interested. Yeah.
Okay.
Yep. So now we're going to go into our guest speaker, we're going to have a presentation on Medicaid 101 and also a presentation on the federal access rule. Can you go to the next slide, please? So we are really honored that Janine Zalowski is able to join us today. She's with the National Association of State Directors of Developmental Disability Services. She serves as the Director of Technical Assistance and Special Projects. And she's going to share a presentation with us today with the Medicaid 101 and then also touch and go into the access rule. So Janine, we're going to turn it over to you.
Thank you so much. It's an honor to be here. Can you hear me okay?
Yes, Janine, we can hear you. And if you'd like to present your screen.
Sure will. Give me a moment. It's, I'm not used to working in this platform, so I think I have it though. Let me know. Share. Okay. Sorry about that. Okay, let me go into slideshow. Okay, are we all set?
Yep, Janine, we can see the slide, but we also see the side panel ones. Is there a way you can make it full screen? It doesn't look like it's presentation mode on our screen.
It is on presentation mode in yours?
No, it is not.
Oh, okay. I'm so sorry. Let's see. Slideshow from beginning. I'm just trying to see where that would be, Rhonda. I usually just do from beginning and the whole slide is taking up my screen, but let me just see.
Janine, you may be presenting a different screen if you have more than one monitor.
I do.
Okay, so it's probably not pointed to the monitor that has the full screen showing.
Okay. Okay. One more moment. Let me try something else. 1 second. I don't know, Rhonda, it's just working.
And when you go to your screen,
Display.
there are two options. One is entire screen and one is or entire window or screen.
Did you get?
You can select
Can you see?
entire one and then point to the specific one with the full screen.
Can you see it full screen now?
No, we cannot.
Okay.
So Janine,
Yeah.
we can present from your PDF from here if that would be easier.
That'd be great. I'm sorry. I don't want to take up more time trying to figure it out. I'm so sorry, everyone. You're dealing with not the most technologically savvy person. So my apologies.
All right, I think we should be presenting from here now. So just let me know when you want to go to the next slide.
Okay, thank you so much. My apologies, everyone, for the technical difficulties, but I hope everything is good now. As Rhonda said, my name is Janine Zalowski. I'm the Director of Technical Assistance and Special Projects at NASDS. We are the National Association of State Directors of DD Services. We support all 50 states, the District of Columbia, Guam, and Puerto Rico. And I'm just delighted to spend some time with you today. As Rhonda noted, I am going to talk briefly about Medicaid basics and the access rule, and also some hot off the presses changes to the CMS technical guide. And Rhonda, another thing I want to say is if I am getting close to time, just give me a nudge and I will speed things up. Oh, go ahead.
Thank you. Sounds good.
Okay, great. So whenever you hear the term Medicaid, I'm sure there's a couple things that come to mind, like, my goodness, it's not rocket science, it's far more complicated. That's what used to come to my mind a lot, but I have many, many years of experience talking about Medicaid now. So I like to start off with a little bit of humor, because once you know the basics and the tools, it's really not that complex. We need to figure some things out. You know, we might wonder why a policy is what it is at a state level. We might try to navigate as a support coordinator, supporting a person and their family through the Medicaid. But I'm here to tell you that once you know the basics and have the right tools, it definitely becomes less complicated. Next slide. So let's head on into the basics. Next slide, please. I always like to start with a visual, because Medicaid interconnects and sort of builds up on different pieces of its structure. So the tree that you're looking at really is a visual depiction of the structure of Medicaid when I put my mind to it. So the bottom, where you see all that roots and foundations, those are all the things that I call the rules of the road and the requirements. The trunk holds the bulk of standing this tree up, and that's all the Medicaid mandatory and optional benefits and all the different eligibility groups that states can use, as well as some other program features and requirements that we will cover. So basically, that root and foundation is everything on who the program supports. And the leaves, the branches on the left and the leaves on the right, which I deem the more free-flowing pieces, are things like the 1915C Medicaid waiver we're going to talk about. And also there's some demonstrations. These are all things that are exceptions to regular business and really support individualized supports and services. Next slide, please. So if we turn back the clock and go down to the Medicaid sort of trajectory, Medicaid was authorized in 1965 by the Social Security Act. It was signed into law, the Social Security Act, in 1935, really to provide social security and unemployment protections for Americans. In 1965, it was amended to include Medicare and Medicaid. And as you all know, Medicaid is the largest health insurance program in the United States. We are probably at, I looked at this data back in November of 2023, and there was 78 million people enrolled in all 50 states and the District of Columbia. That has risen exponentially. I can get you the most accurate figures, but we're looking at well over 80 to 90 million people. People enrolled in Medicaid have rights to payment for health care that is medically necessary as defined by law. The federal government is required to fund a share for those costs for those services to states. And there's a link at the bottom here that will take you to the reports on Medicaid and CHIP enrollment, so you can see some of the newer figures if you'd like. Next slide, please. Some more of the basics to understand the structure around Medicaid. It's a state and federal partnership. So that means both the federal government and your state government, DDA, contribute to the cost of Medicaid in the state. So states must spend their own money or their localities, counties, for example, money to assess Medicaid fund. And the amount of money that the federal government contributes for Medicaid services is different among states. And that's varied by the size of your state, the gross per capita income of your state. But most states get at least 50% match for their state share. Next slide, please. So let's begin with the chunk of this, and we'll talk a little bit about Medicaid eligibility. So I noted that the original Medicaid program gave medical coverage to individuals receiving cash assistance, for example, but over the years, eligibility has expanded to cover way more populations. Today, Medicaid beneficiaries include low-income families, pregnant women, children, individuals with disabilities, seniors, and individuals in need of long-term services and supports. Under the Affordable Care Act, which is referred to as ACA, states really had the option to expand their Medicaid programs to cover low incomes, to cover individuals with maybe low incomes, non-elderly, and also childless adults. So as of 2022, 38 states and the District of Columbia have expanded Medicaid to cover an expanded population. Next slide, please. I had mentioned that it's a partnership. Medicaid is a partnership. So in that partnership, there's the Medicaid Single State Agency, which is your Medicaid office in your state. States have to designate a single state agency to administer or supervise the administration of the state's Medicaid plan. Now, states can delegate functions to maybe the agency, like the DDA agency, to fulfill some of these obligations, and also contract with other public or private entities to perform functions involved in the administration of the Medicaid plan. So state IDD agencies are often the operating agencies for these Medicaid programs in a lot of different aspects. Next slide, please. So in Medicaid, there are some overarching coverage and payment requirements, and these are found in Section 1902 of the Social Security Act. And these are really the foundations and what we call the rules of the road. I'm going to highlight a couple of those for you to give you an understanding. The first is statewide-ness. Most Medicaid benefits must be available on a statewide basis, but a Medicaid waiver, on the other hand, can allow a state to waive statewide-ness. Due process. You have to have the right to appeal adverse actions. People may challenge what they feel are unlawful denials of Medicaid coverage or care and support. So individuals have the right to due process. Anyone can apply and make an application for services, and those services must be furnished with what Medicaid calls reasonable promptness. And CMS doesn't say what the reasonable promptness standard is. They really let states set their own standards, but most states, maybe start their services within 90 days or 60 days as their reasonable promptness standard, but it varies. Free choice of all willing and qualified providers. So if you're in the 1915C waiver and you need a specific service, you can pick any of the providers that signed on with DDA to provide that service. Comparability. Some Medicaid benefits are available to everyone that is eligible, and we're going to get to those in a minute. And then the last, Medicaid is the payer of last resort, and this is almost always. So if another insurer or a program like early periodic screening and diagnosis testing, EPSDT, vocational rehabilitation, for instance, if another insurer or program has the responsibility to pay for costs incurred by a Medicaid eligible person, that entity is generally required to pay all or part of that cost of the claim prior to Medicaid picking up any payment. Next slide, please. I am not going to read all of these services, but this is a snapshot for you of all the mandatory services states must provide via Medicaid, okay? You'll see I mentioned PSDT, early and periodic screening, diagnosis, and treatment. You see rural health clinic services, outpatient services, inpatient. So this is just a reference for you to have on hand of all of the mandatory services a state must provide via Medicaid. Next slide, please. There are also optional services which aren't listed here, and that is up to the state's discretion. So there are some other optional services that a state can choose to provide, and that is solely up to the state. But one of these mandatory services that I really want to delve into for just a minute is the early periodic screening, diagnosis, and treatment. This is important to mention because it's the child health component of Medicaid. It is an entitlement. It is, there are federal statutes and regulations that state that children under age 21 who are enrolled in Medicaid are entitled to these EPSDT benefits. And states must cover a broad array of preventative and treatment services. So what that means also is all of those mandatory benefits that I mentioned and the whole bunch of optional benefits. If a child under 21 in EPSDT needs any of those, they need to be provided. So EPSDT is early meaning assessment and identifying any problems with kids under 21 early. Periodic, we want to check children's health at periodic and age-appropriate intervals. We want to screen for physical, mental, developmental, dental, hearing, vision, all of those important well categories to detect potential problems. Diagnosis and diagnostic. We want to perform diagnostic tests to follow up when a risk is identified. And then lastly, treatment. Control, correct, or reduce health problems that are found for kids. So EPSDT is an entitlement for kids under the age of 21 who are enrolled in Medicaid. Next slide, please. There are what I call the alphabet soup of Medicaid authorities in Medicaid. You might hear letters of C, I, J, K, and they're all different ways in which you can operate the program. I'm going to focus today on the 1915C Medicaid waiver because it is the most common Medicaid benefit important to people with disabilities. The second, I would say, is the 1915I state plan. But the 1915C by far, and you have several of these in Maryland, is the most common, and it's used across the country most commonly. So I'm going to focus on that one today because we would need probably the whole day for me to go through all the different authorities. Next slide, please. There's a saying that if you've seen one Medicaid waiver, you've seen one Medicaid waiver, and that is so true. Medicaid waivers across the country are very different depending on a state's needs. But one thing is for sure, there are so many interdependencies. So nothing stands alone in Medicaid, and every decision that is made in a waiver application impacts something else. Next slide, please. So I mentioned those rules of the road before that I showed you on the screen. So Section 1915C of that same Social Security Act allows states to ask for waivers of existing Medicaid rules, those rules of the road, statewide-ness, comparability. So those can be waived. The waiver began in 1981 as a means to correct the institutional bias of Medicaid funding. The idea was that states can use the Medicaid money for community services that would have been used in an institution. So home and community-based waivers were established to meet the needs of people who prefer their long-term care services and supports in their communities rather than in an institutional setting. President Reagan signed this into law based on the heroism of Katie Beckett. Can't say enough about Katie Beckett and her family. They said, you know, why can't we get these supports? Why can we only get them if Katie's in the hospital away from us or in an institution, but not if she lives in her own home? So the Katie Beckett waiver was also established, so kids with intensive medical needs can get their services at home as well. So this was a huge turning point in serving other populations that really, truly did not exist before 1981. What I want to say here is this does not mean you have to go to an institution or even want to go to an institution. It's just that you could be eligible for services in an institution to get the 1915C waiver. Next slide, please. So it was this 1915C allowed states to ask for waivers, again, of the existing Medicaid regulations. The idea was that states can now use the Medicaid money for community services that would have before only been used for a person in an institution. HCBS waiver services, though, are tied to institutional eligibility. Again, I want to keep saying this does not mean you have to go to an institution or even want to. It's just the eligibility is tied to it. And the waiver means that states can offer all of these wonderful services and supports in community settings. Next slide, please. If you were to look at a waiver application, and I mentioned to you that these are very different across the country, and it's because of these things too. There are a few types of services that are allowable in waivers. The first is statutory services. These are include all different types of core service descriptions that are in the 1915C waiver technical guide that a state can look at. These are the services that are specifically authorized and included in the 1915C of the Act. So all of those services were in the Act. They're the statutory services. And even though that's true, the state can also specify the scope of the service as long as it aligns with that core service definition. That's considered a statutory service. Then there's a bunch of other services we deem as other services that a state can request to offer that are not expressly authorized in the statute, but if it can be demonstrated that the service will be necessary to assist a waiver participant to avoid institutionalization and function in the community, you can provide those other services in the waiver. And then lastly, there's extended state plan services. So there's a whole list of therapies, for instance, that are in a state plan, but a state may augment the services that it provides under the state plan in the waiver, but they can't duplicate. They have to be above and beyond what is considered medically necessary under the state plan, if that makes sense. So those are the types of waiver services that can be within a waiver. Next slide, please. A state can also elect, I want to make sure this is at the election of the state, to allow self-direction in the Medicaid waiver. So participant direction of waiver services means that the waiver participant has the authority to exercise decision-making authority over some or all of their services. And they accept the responsibility for taking a direct role in managing them. And in self-direction, you know, a state elects what services they'll allow to be provided through self-direction. So a person may have some self-directed supports in that they're utilizing, some traditional supports, but it's at the state's election of what services can be provided. Participant direction promotes choice and control over the delivery of waiver services, including who provides them and how they are delivered. For For an example for you, the participant may be afforded the opportunity to recruit and hire and supervise all the people who furnish supports to them during the day, and also terminate an employee who is not performing in a satisfactory manner. When a waiver services provider managed, a provider selected by the participant carries out these responsibilities. So again, you can have a combination of both. Incorporating participant direction in a waiver involves several interrelated dimensions of this waiver. So it can permit participants to direct some or all of their services, or just opt out instead to receive only provider managed. So that's where, as long as the state allows it, the person can make the decision of what they want to do. If they want to have a couple of these models involved in supporting their support, it is up to them. Next slide, please. So what do the waivers look like today? It's probably over $900 and some billion are spent nationally on Medicaid long-term services and support. And home and community-based services, which is that 1915C waiver, for instance, takes up a whole big chunk of that budget. Medicaid coverage of HCBS, as I noted, varies by state, can't say that enough, and includes a combination of all the medical and non-medical services that a person needs. I listed here on the slide, things like case management, homemaker, chore services, home health aid, personal care, respite, many that you will see in your 1915C waivers in your state. And lastly, HCBS programs serve a variety of targeted population groups, such as people with intellectual and developmental disabilities, physical disabilities, individuals who might have a substance use disorder or a co-occurring mental illness. So there's a lot of opportunities for Medicaid beneficiaries to receive services in their homes and communities. Next slide, please. So that was a very highlighted and quick primer of Medicaid. If you go to the NASD's, NASDDDS.org, we have a lot of wonderful resources on Medicaid and Medicaid services. So you can access some of those as well if you'd like to go into those topics a little bit deeper. But as I noted, it would take a long time of our agenda to cover exactly everything. But I wanted to give you the foundational pieces. So I'm going to move next into talking about the ensuring access to Medicaid services, final regulations, which were effective July 9th of this year. There are many different due dates for the pieces of this regulation, of which I'll highlight for you all, but it is another watershed regulation, right up there with the HCBS settings rule. And this rule really seeks to increase a couple of things: transparency, accountability, standardized data, standardized monitoring, and create opportunities for states to really promote access. Next slide, please. So there's a couple different pieces to this rule. It's very, very large, very expansive. And I tried to distill it down to the most pressing pieces of the regulation. And again, on the NASD's website, we have so many different resources that were developed by our team who, has the responsibility to and the joy to read these regulations cover to cover. First is payment adequacy. Next slide, please. So you might often hear payment adequacy as the minimum performance standard. And what that actually means is the state must ensure that 80% of Medicaid payments go to the compensation for direct care workers for 3 services. And, we kind of think, these services are widely used. It may be CMS's initial foray into this data, but it's for personal care services, home health aid services, and homemaker services. And the compliance timeframe for this is 6 years from that effective date of July of this year. So CMS is giving time due to those comments on these regulations that states really have to set up MMIS systems to get at this information, maybe do attestations with providers to make sure 80% of those payments are going to the direct care worker. So there is a couple of years for states to really set the structure up to implement this regulation. Next slide, please. There's also a reporting requirement here. So, you know, states are required to make sure that that's happening, and then they must report to CMS annually on the percentage of those total payments for, again, personal care, homemaker, and home health. But they added another service just to the reporting, and that is HAB services. And we're all anxiously awaiting the definition of habilitation services because we know, you know, there's residential HAB, there's a day HAB, there's services that might have a habilitation component like employment. So the state, and this was new, the state has to report, and separately for all of those services, the percentage of total payments that goes to the compensation for direct care workers. Now, they also have to do it within each service and separately report it for self-directed services. So if you allow self-direction for personal care, homemaker, home health aid, and HAB services, you have to report that information separately for self-directed services. And then also you have to separately report services with facility-related costs, maybe like your day HAB. And there's a whole lot of information on, you know, what's excluded, you know, what are facility-related costs in the guidance that CMS initially put out. And the compliance date for this one was 4 years after the date of the regulations in July. And don't fret if you're trying to think, oh, well, when is that? I will show you, and at the end of this presentation, we have a wonderful slide that has all of the different reporting periods and access rule timeframes that you can see at a glance if you're curious when each piece has to be implemented. Next slide, please. There's also a rate analysis and disclosure that has to happen. So a state has to develop and publish a rate analysis all the time. And you know, you may already have that publicly. Some states do. But a rate analysis between Medicaid fee-for-service rates and Medicare rates for services such as primary care services, obstetrical, gynecological, and outpatient behavioral health. So there has to be a comparative analysis on those services. And a state must publish rate disclosures for fee-for-service, personal care, home health aid, homemaker, and HAB services, those services where we talked about that the state has to report on the percentage of the payment. That also has to be published rate disclosures for those. And that rate disclosure must be updated every 2 years and include things like what's the average hourly payment rates? And these are separated by agency, as I noted, and self-directed options, stratified by the population of people receiving those services, the provider types and locations, the number of Medicaid paid claims, and the number of beneficiaries who received a service within a calendar year. So that 6-year timeline, you can see the great detail that this reporting and these disclosures are going to take for a state. So they need to be able to have enough time to ramp up to do all that reporting. Next slide, please. So I want to spend some time on health and welfare and critical incidents. Next slide, please. So in this access rule, and before the access rule came out, CMS did a lot of surveys with states on their critical incident management procedures. So, and they had a vendor who really spent some time analyzing all of this and the data that was reported before the access rule came out. So the first assurance about critical incidents is that the state has to have a system that operates and maintains that system, and that incident management system has to do many different things. It has to identify incidents. It has to be able to have the reporting of incidents. It has to be able to triage incidents, investigate them, and put in the results, resolve the incident, track them and trend them to make sure you're not seeing any trends or might require a policy change. So that system for a state has to be in place by July 9th, 2027. Next slide, please. And there's new reporting requirements. So right now, a state on performance measures that they have in the waiver, they report on those measures every year. There's new reporting requirements that for some of the system pieces. So the state must report every 24 months on the results of that incident management system assessment to really demonstrate that it meets the requirements. So every 24 months, they have to report on how their system tracks, trends, triages, etc. Now, CMS said, hey, there's a lot of states out there that have really strong incident management systems. So if we're pretty confident that it meets all those pieces, we may reduce the frequency of the reporting that the state has to do to once every 60 months, okay? So that's going to be determined by CMS and worked out between the state and CMS. Next slide, please. There's a new definition of critical incident, and that definition for states has to include at a minimum verbal, physical, sexual, psychological, or emotional abuse, neglect, exploitation, including financial exploitation, misuse or unauthorized use of restrictive interventions or seclusion, med error resulting in a telephone call or a consultation with the Poison Control Center or emergency department visit or urgent care or a hospitalization or a death or an unexplained or unanticipated death, included but not limited to a death caused by abuse or neglect. So this is a new definition that states have to comport to. Now, there are a lot of states that go beyond this in their critical incident systems, and they are allowed to do that. It's a great practice. This is just the minimum, the floor on that quality of HCBS, okay? Again, this is just a slide that tells you about the critical incidents, the new information system that enables all of that electronic critical incident data and the state's tracking, including the status and resolution of any investigation that's happening and their trending. Next slide, please. There's also some new identification requirements. So the state must initiate an investigation within state-specified timeframes. So the state has an investigation process that's well known across the state. So they have to initiate an investigation within their timeframe and report on that for no less than 90% of critical incidents. So the threshold currently is 86%. It's been raised to 90%. The state also has to complete an investigation and determine the resolution of the investigation within state-specified timeframes for no less than, again, 90% of critical incidents. And then lastly, the state has to ensure that corrective action has been completed within state-specified timeframes for no less than 90% of critical incidents that require corrective action. So it's reporting, it's all of that reporting in the state specified timeframes. It's using claims data and fraud control unit data and data from other state agencies, such as Adult Protective Services or Child Protective Services, to the extent permissible under your state applicable law. And this is the big one for states, because there is a notation that in this rule that if there's a or sister organization or the police or anybody that's going to separately investigate a critical incident, if the investigative agency fails to report that resolution of that investigation within your state specified timeframes, then the state has to really, this was intended to ensure that the failure to effectively share information between state agencies or other entities in the state, that the state is responsible on the hook for investigating incidents, and that it does not impede the state's ability to effectively identify, report, triage, investigate. So if any of these agencies aren't giving the state back the information within those timeframes, the state has to get involved and be able to investigate itself. So, you know, ensuring that there is enough sharing on the status and resolution of investigations. And that is 3 years, again, after the effective agreement or date, because states have to, you know, maybe they're going to develop data use agreements or information sharing agreements between the state and some of these other entities that are responsible for critical incidents. And my screen just, okay, went blank, but I think I'm okay. Sorry about that. Okay. Next slide, please. Next slide. Thank you. Okay. We're going to talk a little bit about the timeliness of access reporting. So the final rule, as I noted, adds habilitation to the list of those other services, homemaker, home health, personal care. And the state's going to report on 2 timeliness factors. Beyond, you know, this is another extra reporting. The average amount of time for when homemaker, home health, personal care, and HAB services are initially approved to when the service began, for all individuals newly receiving services within the past 12 months. So this hits that access to services. So they want to know the average amount of time for when the service is initiated and from when it was approved, okay? Also, the percent of authorized hours for those services that are provided within the past 12 months. So 2 additional timeliness, that access reporting requirements. States may report these metrics using random sampling of beneficiaries. And the final rule specifies that the reporting is for individuals, again, newly receiving services within the past 12 months, rather than for individuals that are newly approved to begin one of these services, if that makes sense. And the effective date, again, for that is 3 years. Next slide, please. CMS is also interested in a state's waiting list reporting requirements. Okay, CMS doesn't tell states how to operate waiting lists, but they're going to have to report now a description of how they maintain the list of individuals who are waiting to enroll in the waiver program. If the state has maybe a cap or maintains a interested parties list, you know, however the state is operating its waiver waiting list, they have to, and this description has to include, you know, what does your screening process look like? You know, do you screen? Do you rescreen people? What's the frequency of rescreening? How many people are on that list who are waiting to enroll in the waiver program? And what's the average amount of time that individuals newly enrolled in the waiver program in the past 12 months, how long were those people on that waiting list before they were enrolled in the waiver? So Those are some additional reporting requirements for states on their waiting list. And that again is 3 years as well, July 9th, 2027. Next slide, please. I want to talk a little bit about a new CMS HCBS, Home and Community-Based Services Quality Measure Set that came out. Next slide, please. So what this is a set of nationally standardized quality measures for Medicaid-funded home and community-based services. Right now, in a state's waiver application, there are a couple of areas that they report on. For instance, they report out on their plan process. They report out on incident management. They report out on on financials. They report out on things that they delegate, the Medicaid agency delegates. All of those things are going to go away because there's a set of nationally standardized quality measures. And CMS wants to do this because they want to report more or promote more common and consistent use within and across states to get that data to look at it comparatively. They want to create opportunities for states and CMS to do that comparative data analysis on HCBS services. They want to drive improvement in quality of care and outcomes for people receiving HCBS. And they want to support states' efforts to promote equity in their HCBS programs. And they also want to take away some of the administrative burden from states, reporting on those things that they do all the time. Eligibility, re-eligibility determinations, just to name a few, that the state does really well. It's part of their everyday practice. Why do they have to report out on these things when they don't get at the outcomes of people they're supporting? States must establish performance targets reviewed and approved by CMS of each mandatory measure. So the state's going to establish targets that CMS is going to approve. The state's going to describe their quality improvement strategies and what they will do to pursue to achieve performance of the measures. And the state may establish these targets and strategies that even for measures that are not yet required but will be, and on populations for whom reporting is not yet required but will be. And what I mean by that is, if you're a state that is a money follows the person state, you're going to be implementing this quality measure set ahead of any of the states that do not have a money follows the person program. Okay. And CMS is getting ready to be putting out some really detailed guidance on the HCBS quality measure set. They put out a letter in the summer about this, but they're really getting ready to put out some additional guidance. In the quality section as well of this rule, the Secretary of HSS is able to make technical updates and correction to these measures. And these are going to be every 2-year updates. Okay. So that's the Secretary is going to ensure that all the measures reflect evidence-based process, including testing and validation, and more importantly, that they're meaningful for states and are feasible for state level, program level, and provider level reporting. So in that analysis, the measures may change every 2 years. And the Secretary of HSS is going to begin identifying quality measures no later than December of 2026. So we'll know more about this soon. And lastly, again, I said this replaces all of those measures that are in a waiver for 86% performance level that all came out in CMS's 2014 guidance. So although states may, and importantly, still be collecting this information, they don't have to report out to CMS on it. States will report every other year on all the measures instead of every year that are identified by the Secretary. And CMS then will put some reports out on a subset of the measures for comparison. And this is for all waivers. See, I, K, and 1115 demonstrations, okay? The only thing that's not included in this is 1905 state plan services. Next slide, please.
And Janine, if we could just note, we have about 10 minutes remaining. We
On
want to,
is in these regulations is fee-for-service grievance processes. Next slide, please.
sorry, Janine, we'll want
State has
to
to, if they don't have it, a grievance process in their 1915C waivers and the rest of the authorities. And they defined what a grievance is. It's defined as an expression or dissatisfaction or complaints, okay? And again, I want to say that this system for grievances is separate from the fair hearing process and that due process that I talked about in the beginning of that presentation. That's still there. This is about expressions of dissatisfaction or complaints. CMS clarified in the final rule that grievances may be filed related to the state or a provider's performance. It used to read compliance. It reads now performance with person-centered planning and the HCBS settings requirements. And the compliance date for this one, it's coming pretty fast. It's 2 years following the effective date of the rule. Next slide, please. Some other notable details on the fee-for-service grievance side is that beneficiaries or their authorized representatives or other disinterested individuals or entities who have the permission of the person, the beneficiary or their authorized representative, may file a grievance or support a person to file that grievance with no punitive or retaliatory action taken because of filing that grievance. So anybody can help the person file the grievance. The state must resolve that grievance within 90 calendar days and as expeditiously as a beneficiary's health condition requires, with the option to extend an additional 14 days if the person is amicable to that. Because CMS didn't want to finalize a separate expedited grievance pathway, which they did in the original, but now they're saying, you know, listen, 90 days is reasonable, but as also expeditiously as a beneficiary's health condition requires. Information on the grievance process must be provided to everyone in plain language, to new and current beneficiaries, with reasonable assistance in navigating the process. So someone wants to file a grievance and they come to you and they're not sure or they don't know what to do. The state has to make sure that they're able to help the person, including anyone with limited English proficiency and people with disabilities. Any help that is needed must be provided. Next slide, please. The last piece that I'm going to talk about on the access rule is the Medicaid Advisory Committee and the Beneficiary Advisory Committee. Next slide, please. So Medicaid advisory committees have been in existence for an extremely long time. I know you have one in your state. The rules on those have not been updated in, I can't tell you how many years, but probably since the inception. So this access rule restructures the current medical care advisory committees into two distinct bodies, the Medicaid advisory and the beneficiary advisory. And I want to say there's a third group in this rule called the HCBS Interested Parties Advisory Group. And that has to do with those slides that I went over on rates and things like that. So that group is concerned about payment recommendations, okay? And rates. And so there's a separate group, but if you have the Medicaid Advisory Committee and they want to dedicate a part of that agenda to discuss rates and payments, and the Interested Parties Advisory Group can come to that, that is perfectly fine. You don't have to have a separate meeting if you don't want to. And this one is very quick. This is the quickest out of all of them. It's 1 year following the effective date of the rule. So this is July 9th, 2025. We're cruising right into 2025. Next slide, please. So I'm going to deem these as MAC and BAC because on my slide I described them. So the Medicaid advisory group and the beneficiary advisory committee are selected by the Medicaid agency leadership. But oftentimes what CMS found when they were going out to different states and looking into these groups is that the group never changed, same people on the group, etc. But this rule makes it mandatory to have rotating terms to really promote diversity of viewpoints. So you can't serve on this group 2 terms in a row. Nope, it switches every year. So that was something that was really important in the reg. The MAC, that Medicaid Advisory Committee, must have a state and local consumer advisory groups representing the interest of Medicaid recipients, clinical providers or administrators, and there's some suggested categories in the regs, including providers of services to people with disabilities and people over age 65. If you operate managed care in your state, managed care organizations, other state associations, other state agencies serving Medicaid members. And these folks, though, are non-voting ex officio members. So if you do have other state agencies that are part of the MAC, they're not going to be voting members. The BAC, the Beneficiary Advisory Committee, must be composed of people with living experience, Medicaid experience, including current or former recipients of Medicaid services and their caregivers and their family members, and maybe some of their unpaid caregivers. So one other piece I want to say about this is this Beneficiary Advisory Committee, 10% of it, of that committee has to be on that Medicaid Advisory Committee. And that's effective by July 9th. So 10% by July 9th has to be also part of the MAC, 20% 2 years after the effective date, and 25% of the Beneficiary Advisory Committee must be part of that MAC 2 years and beyond. Okay, so given states some ramp up time to getting people acclimated into that Medicaid Advisory Committee too. The MAC and BAC must meet on a quarterly basis. And as I said, that percentage of folks that are on the BAC has to be included in the MAC. And those BAC meetings are going to be held before the MAC meeting. So people can make sure that all of that rich information that is talked about at those beneficiary advisory committees, that is brought to those Medicaid advisory committees, if that makes sense. Next slide.
Janine, can you hear me? Janine?
This is the Medicaid agency, and are, to consider an array of topics. Topics were mentioned in the regs. So they're including, but not limited to, service additions and change quality, coordination of care, eligibility, enrollment, and renewal processes, beneficiary and provider communications, cultural competency, language access, health equity and disparities, and biases in the Medicaid program. So those are topics that CMS said should be considered. That Medicaid Advisory Committee recommendations are to be made to the Medicaid agency in a formal report with which the agency will finalize and publish. So the first report of this Medicaid Advisory Committee is to be finalized within 2 years. So 2 years from July of this year, okay? And then next slide, please. This is what I said is a really handy timeline for the proposed access rule that you can make note. I just noticed on here, I had subject, final reg. This is the final reg, and this is the timelines in the reg, okay? So that is something that you can just go back to and look at when the state has to implement each of these pieces.
Hi, Janine, can you hear us?
Let me take a pulse check, Rhonda. I know I've been doing a lot of talking, and I appreciate you all listening to those two large topics.
Janine?
Our
Janine?
scan time. Do you want me to go through a couple of quick updates on the CMS technical guide?
No.
So Janine, can you hear us? Can you
Janine?
hear us?
Rhonda?
Janine, can you hear us?
Oh,
Can you hear us all right?
Can you hear anybody?
Janine?
Rhonda raised a hand. Something I'm gonna do.
So Janine's now muted. You want to proceed?
Yeah, we better.
Okay.
Go ahead, put up the slide deck.
Okay.
Sorry, we apologize. As you can tell, we were having some challenges being able to communicate with Janine, but very important information about Medicaid.
You all still hear me?
Janine,
Yeah.
can you hear?
Okay. I'm just waiting to see if you want me to go over any slides on the waiver technical guide, and I did send them along so that they could be on screen if we have enough time. If not, they are there for everyone to view at another time.
So Janine, are you able to hear us?
Here, Rhonda.
Are you able to hear us? Okay, let's go ahead and move ahead.
So again, we apologize for the technical difficulties there, but the Medicaid 101 and the access rule is very important. We'll be talking about this information more, and additional information about the technical guide new requirements that are coming out. We'll also bring that up and share her slide from there. So if we could present the slide deck again. We wanted to share a couple updates. So as we're bringing that up, I just wanted to kind of move on so that we can make sure we get some of these other updates going.
Thank
We were going to talk a little bit about the policy updates. And so we wanted to let you know that we are working on 2 specific updates that we want to be sharing in the near future. One relates to person-centered planning. We have our person-centered planning policy that's on the website currently that you can access. So we're going to be updating that for some additional information, such as the self-directed service forms that are required, as we've noted in our self-directed comprehensive policy and manual. The second policy update that we'll be sharing in the near future relates to medical daycare services. Medical daycare service is one of our waiver services in our programs. It was recently added to person-centered plan in the LTSS system, the LTSS Maryland system. That is the state's database public health record for the programs that we operate. And so we're going to be sharing the policy on medical daycare and a manual so that we can let people know more about the service. It'll provide guidance for our case managers to make referrals. It'll provide information for providers in terms of the steps that they would take in terms of, you know, signing signature sheets and such, so that we can make sure for those individuals who have that assessed need for medical daycare services are able to have information, understand, and be able to access their services. So we'll be sharing that after the first of the year in the near future. Now I'd like to turn it over to Karen Lee so that we can get some updates related to the waiver recommendations work group. So Karen?
Yeah. I apologize for the people online. I had a PowerPoint so you could see what we're going to say in here, and I didn't understand that there was an option. But for people who don't, auditory is not as easy. I have written down what our recommendations are so far in the process that we're doing. So if folks want a copy of that, because I know not everybody's auditory learners, and so this is a better way for folks. But the subcommittee for waiver recommendations, rather than having a single leadership person, we've decided to rotate leadership amongst the members. The current members are myself, Stephanie Watkins, Matt Morgan, Rachel London, Rob Baynard, Jessica Solomon, Teresa Titus Howard, Alex Fitzgerald, and then my assistant, Maya Gillette, is helping us to structure and report out. The structures of the meetings, the way that we're structuring our meetings is that we're preparing by researching a topic, kind of like we did today. We're discussing that topic, and then we're breaking up into groups if that's easier for us to do going forward, and then we make a recommendation back to the council. So we, this is the waiver is huge. How many pages? A few. 495, something like that, and it's heavy content. And so we created a paradigm that we are going to, or a model for us to be able to break it down into smaller chunks that we can do. So we started off by looking at the macro, or the really big picture, which is really about things like, at the macro level, we were looking at things like how many waivers, what should the people be in the participation be in the waivers, and looked at a couple different states and the different models. And so that's what we've done so far, is we looked at what we call the macro level, or the big picture, and we started talking through these issues at a really high level. We've had 2 meetings. So we talked about how many waivers, who is the targeted participant, and what does the waiver we wanted to achieve. So right now, DDA has 3 waivers: a family supports waiver, a community supports waiver, and a community pathways waiver. So we looked at the possibility of other waivers, such as community pathways, autism waiver, a family directed waiver, and a self-directed waiver, looking at separate options to be able to do. And ultimately, the group, after lots of dialogue and some reading and research and so on, the consensus was that if we can follow the waiver, the way that it's currently written, or the way that we're recommending it be written, and that we have regulations to support the waivers, that would be consistent. So our regulations being consistent with what's in the waiver, as well as the waiver being clear about which service is available to which person, that we believe that we can go down to a single waiver. So our first recommendation at the macro level is that we go down to a single waiver. The next step is for us to look at kind of the middle layer, which is looking at eligibility and access, funding structures, and person-centered planning. And then after that's done, we're going to look more at the micro level, which is more about the service definition and the staffing models that are in there. So as I said, we started off looking kind of at the big picture, then we're looking kind of more at the middle, and then we're going to look more at the detail. So we're looking for kind of those three things. But our first recommendation, kind of breaking it out, was that. We do have a couple of asks for DDA that would help us going forward. First is to help understand utilization. We'd like to have some data on which services are used and how often they're used, the frequency, so that we understand what currently is your highest use, and would help us to target that. Second of all, what models of support are most often used, to get some real data on that, about self-direction versus community providers, versus if there's even any other. And then looking at the current waivers, how many people are in each of the current waivers or accessing services, and then looking at the waiting list for those waivers. So those are just 4 pieces of data that we would like to help us to move forward. So I'm opening it up to other members to see if you had anything else to add.
Okay, great. I think 2 things. So we appreciate you sharing the update today, and we know that our February meeting is where we're looking for the kind of full recommendation, so more to come on that. I know at least one member in the chat and also some others may be interested in joining the group, so the waiver recommendation work group is open. Others can join, right? So they can reach out to you, Karen, I assume, or others that's on the group.
Yep, they can, any of us, and we'll get it to Maya and she'll add them to the group.
Excellent. Okay, great. Well, thank you for those updates. You want to send me an email so I make sure I got my notes correctly for the information you're looking at, then we can support those efforts. Okay, great. Well, we want to go to the next slide. Before we open up for public comment, I just wanted
Reachie's got a comment.
Oh, the waiver advisory council, they can have some questions and comments. I have a variety. The council itself might have some questions and comments unrelated to like about the presentation. I just
before we open up to public comment, I want to do two things. So we'll ask about if there's any other comments on that. We shared the minutes from the October meeting. I wanted to see if the council members had any corrections or wanted to have any discussion on the October minutes. Did anybody want to make a motion related to the minutes in terms of accepting them?
I'll move we accept them.
Anybody want a second? I'll second. Okay. Emily.
Okay, so my question is, I know you already have entered the recruitment efforts. Have all seats been filled? 10 seats been filled?
Yeah, Emily, great question. I want to, before I answer your question, if we could just finish the motion on the floor, which is the acceptance of the minutes that were shared. So is there all in favor for the voting members that are in the room and online? If you're
Aye.
you can, okay.
Aye.
Thank you, Josh.
Aye.
Okay, thank you. Any opposition? Okay. Great, then the minutes are passed. Rachel, you had a couple questions about the information in the presentation.
yeah, two. Well, one about the presentation and another question about what you shared. I just want to clarify since we're focused on DDA, Medicaid waivers. Jenny talked about the homemaker, home health aid, and personal care, and the 80% requirement of the rate going to providers. Is it correct that those are not included in any of the 3 DD waivers?
So I will say a couple things about the access rule, and my other DDA members here may have something to say. I would say one, the information that we have and that what Janine has shared is what we have. CMS, the Federal Center for Medicare and Medicaid Services, will be issuing what they call sub-regulatory guidance, which will give us more of the details so that we'll fully understand that. As you heard Janine say, there is a Medicaid state agency and it's someone that's a point on that. DDA is not the Medicaid state agency. And so it's important to know that. There is the Department of Health is the state Medicaid agency. Ryan Moran is the state Medicaid director. So Medicaid and the waiver programs all fall under the Office of Long-Term Services and Support. DDA is an administrative agency. We operate the day-to-day waiver program on behalf of Medicaid. That being said, Rachel, is just that Medicaid will be the point in the lead for our department and we'll be sharing additional information, but we are also waiting for additional information and guidance from CMS to know those type of questions, including what Janine shared about like, how do you define an incident? What's included in that? So more to come for that. And as she talked about the access rule, that the implementation of that is from, you know, some go in maybe 2 years and some are up to multiple years out. So there's opportunities for us to have further discussion, which we'll bring back to the committee.
So you're not.
I don't have an answer to that. I do not have an answer to what is definitely included until we get more federal guidance.
Okay. And you shared about 2 policy updates that are coming, particular to the medical day, since that is a waiver service. Mm-hmm. Are those policies, just policy, let's stick with that, going to be something that this advisory council would be able to review and potentially provide input just for understanding or something before the other advisory council, like, that is how we're used? Is that, I think it sounded like you were releasing it, but I couldn't tell if you were releasing it to us to review or it was being released.
Yeah, what we were sharing was we'd be releasing it to the public,
Okay.
similar to what we did with the self-directed services, and then sharing information. It's based on the federal authority, so what the medical daycare services. It's important to note for medical daycare services that it is part of the waiver, but we do not, the DDA does not license medical daycare providers, nor do we fund them. It's a service, so we are just facilitating that so people can access that.
So the answer's no. We're not reviewing it beforehand.
The committee would not be reviewing it, right, right, and we will be.
And just to clarify, in regard to that policy, it's providing the information on what the service definition is for medical daycare. Also, because we have now made some LTSS Maryland changes to include it in our person-centered plan, informing our team members how, and the case managers, how to include that in the person-centered plan.
But there's no COMAR for it related to this. This is a policy.
Right, this is basically sharing what's in the waivers from the waiver authority that we have, right? There is a medical daycare regulation that people can look at. Related to
So that's not what you're talking about.
That's not.
No.
Okay. And then Emily had a question. So Emily, you were asking if we had more open seats. We do. We have open seats for people on the provider managed service delivery model. So we are looking for more people with lived experiences for that.
Okay.
Other questions from the council? Okay. So we are, Emily, did you have another question?
Yes, I had another question. So I know you mentioned that the DDA will conduct prep meetings once a week. I mean, 1 week for members. Has there been any prep meetings?
Yeah, great question, Emily. Yes, we had a prep meeting last Thursday, and we sent out an email related to that. So we will, as we shared, we will do a prep meeting 1 week before the council meeting.
Well, I did not get I didn't get any information about that meeting.
Okay, well, I will follow up with you and make sure that we resolve if there was any challenges with you getting that email.
Okay, thank you.
Yeah, thank you. Good question. Josh.
Yes. I'm still waiting to hear back because I wanted to join the work group committee, but I haven't heard back from anybody about that. I sent an email.
Great. Josh, we will connect you with Karen Lee and the work group so that you can participate in that. Thank you for letting us know.
Thank you very much.
Great. Any other council member questions, comments? So I know we've gone over, we'll open it up for a few minutes for public comments. So we're going to move to that. We ask that you raise your hand if you're in the room or online, and then we will call on you. We give up to 2 minutes per person. Remember our code of conduct and exercising civility, and that we should not be discussing individual specific information. So if anybody would like to raise their hand, we can call on it. Emily, your hand is still up. I just wanted to confirm that you do not have another. Okay, great. Okay, we have Pamela Haddle.
Yes, hi, this is Pamela Haddle. I work for the ARC of Howard County. And Ms. Rhonda Workman, I understand you, towards the end on a slide, you said something about person-centered planning policy. Could you clarify what you said? You're going to be sharing after the first of the year. That's what I was able to hear.
Yes, great question. So what I said was that for our policy updates, we will be sharing after the first of the year updates to our existing person-centered planning policy that's online. We're going to be including the self-directed service forms that are required to be submitted with the PCP, and potentially a few other updates.
Okay, thank you so much. Have a great day.
Thank you. Next, we have Lisa Lorraine.
Hi, thank you so much for calling on me. I'm Lisa from Jubilee Association of Maryland, specifically the Breaking Barriers program. I'm also the co-chair of the Maryland Equity Coalition for People with Disabilities, and specifically wanted to address the waiver recommendation work group. In 2022, I had submitted a waiver comment on behalf of 9 service providers, specifically addressing kind of equity issues for eligibility to the waivers and access, and kind of recommendations around limited English proficient populations, training on cultural humility, and other things that would really provide more access to underserved groups. So I will go ahead and email that to Karen, and would really appreciate if you all would review that during your work. Thank you.
Thank you, Lisa. I think there was a hand in the back. Yes, Andy?
Yeah, it's really just a comment and a request for reconsideration that at least the Waiver Advisory Council have the opportunity to provide feedback to the 2 policies before they're released publicly.
Thank you. Others? Others in the room? Others online? Okay. Having seen none, we apologize for going over and some of the technical difficulties that we've had. We look forward to Charlotte joining us as the co-chair. So Charlotte and I will be teaming up, working together as we move forward. Our next meeting is in February, and that's where we'll be looking for the recommendations from the waiver work group, and we'll continue to work to enhance our process and be supportive of the committee. So if you have any questions, please reach out to Charlotte and I, and we're happy to support you. So thank you, everybody. Safe travels.